Hello. Hello. Am I audible? Okay, that's great. So let's start our discussion today, right? So today we are going to discuss brainstem, and along with that, we are almost done with most of things from Dr. Najib's lectures. Then we'll be transitioning to our first aid, right? Then we are going to start learning from first aid, right? So okay, so let's start.
Okay, doctor.
Okay.
Doc, you don't mind, can we have the lectures PDF also? The Najib lectures, because most
PDF.
of us do.
Okay. I'll just send it to you, no problem, right? Brainstem.
You
Okay,
can
those are
submit
some
it.
handwritten notes. So you guys can just read it, right? Okay, so brainstem. So do you guys know what is brainstem? It's basically a generalized term used for, the stem of brain. The stem of brain is basically made up of your midbrain, your pons, and your medulla. And on the back of them, you have cerebellum, right? So these midbrain pons and medulla together are basically called as brain stem, right? It's the stem of your brain, right? Okay, so let's discuss our midbrain first, right? Our midbrain. We know that, like for example, if this is your cerebrum, then you're going to be having your midbrain, pons, medulla, and spinal cord, right? So we are talking about midbrain. Embryologically, the midbrain is basically derived of a structure called as mesencephalon, which we'll be discussing today in our embryology once we are just discussing it from first day, right? Mesencephalon, right? Okay, what is going to be the supply, the blood supply of midbrain? So if you guys know, we already did the blood supply, right? And yesterday I just told you guys that tomorrow we are going to discuss which specific area is going to be supplied by which blood vessels. So you guys already know the names of the branches of the vertebral arteries, the spinal arteries, basilar artery, pica, superior cerebral artery, and posterior cerebral artery. You guys know that, right? So let's discuss the midbrain is supplied by which branches of that blood supply. So keep in mind the posterior cerebral artery, which is the terminal branch of your vertebral system, if you guys remember, right? And along with that, the superior cerebral artery give branches to your midbrain, which basically supplies your midbrain, right? So midbrain is basically supplied by posterior cerebral arteries plus some branches from, superior cerebellar artery. Is it clear? You guys remember the blood supply? Vertebral joint at this junction.
Yes,
It
doctor.
gives
Yes,
just
yes, yes, Doc.
posterior,
Anterior, final.
basilar, pica, ica, superior cerebral. In the end, you have posterior cerebral. So branches of posterior cerebral and superior cerebral artery give blood supply or supplies your midbrain. Is it clear? What are
Yes.
different structures present within the midbrain? It's really important to know, right? So the midbrain basically is having two nuclei, two cranial nerve nuclei. Which one? The third and the fourth nuclei. The third cranial nuclei and fourth cranial nuclei are basically going to be present within the, okay, they're going to be present within the brainstem, or sorry, within the midbrain, right? What else is going to be present there? Substantia nigra. Do you guys remember what was substantia nigra yesterday? I just told you. Yes.
Yes.
Hello, pars compacta, pars
Yes, yes,
reticularis. It's going to secrete dopamine on D1 and D2 pathway of your basal ganglia. Do you guys remember?
Yes.
Substantia nigra. Okay, so substantia nigra is going to be present within the midbrain. What
Midbrain.
else? Red nucleus, right? Red nucleus. So what is red nucleus? Red nucleus is basically present in the midbrain, and you have a pathway which is known as a rubrospinal pathway. Rubrospinal pathway, right? Which goes from the from the red nucleus into your spinal cord. And what's the function of this rubrospinal pathway? There is a mnemonic in order to keep it the rubrospinal pathways in your mind. That is, sit on a rubber mat. Okay, so rubrospinal pathway, the red nucleus is going to be important for the muscles which are used for sitting. So which muscles are used for whenever we are sitting? The flexors, right? The flexors are used, right? If I want to sit, which muscles am I going to use? The flexors of your lower leg, right? What are the flexors? We discussed it in MSK in detail. Yes. What are the hip flexors? Hip joint.
Is it the quadriceps?
Hello.
Is it the hip flexors? Are they the quadriceps? That's
The
the
hip flexors are quadriceps. Okay, so rubrospinal pathway is basically going to rubber mat for a rubrospinal pathway. Sitting muscles are going to be, the flexors are going to be, this rubrospinal pathway is going to help in the flexors of your lower leg, right? That's really important. Drag nucleus. So we have pre-tactile area, which is also present in the pretactile area present in the midbrain. We'll be discussing the pretactile area once we are doing pupillary reflex, right? So we are going to discuss it there. I'm going to remind you the same pretactile area, right? Then we have medial longitudinal fasciculus. Medial longitudinal fasciculus. What is medial longitudinal fasciculus? Let me just give you an overview. Remember, for example, if this is your eye, right? Okay, these are your eyes. And for example, if I want to look towards right, like that, okay, so basically while looking towards the right, we are using lateral rectus of this eye and medial rectus of this eye. Am I right?
yes, yes.
The lateral rectus is basically going to be supplied by cranial nerve 6, abducent nerve, right?
Sense.
Okay, while the medial rectus is going to be supplied by cranial nerve 3. Am I right? The medial
Yes.
rectus, superior rectus,
And level 3.
Okay. So cranial nerve 3. So you guys can see, in order to properly look towards the right, in order for the both eyes to look towards right, it means at the same time we are going to stimulate the cranial nerve 6 and cranial nerve 3. Am I right?
Yes.
Yes, doctor.
It means that cranial nerve 3 and cranial nerve 6 have basically connection between them, right? They are connected, right? So the cranial nerves are connected via different fibers which are known as medial longitudinal fasciculus, right? MLF, medial longitudinal fasciculus, connects different cranial nerves with one another. And if we have multiple sclerosis, we are going to be having demyelination of these MLF, and which can lead to internuclear ophthalmoplegia, which we are going to discuss, right? So medial longitudinal fasciculus is also going to be present medially within the midbrain. Is it clear?
Yes.
These are the components of the midbrain. And midbrain we know is connected with your cerebellum via superior peduncle, right? So superior peduncle is also going to be a component of your midbrain, right? Superior peduncle. These are the structures present within the midbrain. Is it clear? Hello? Hello?
Yes, it is.
Okay, perfect, right? So this was okay. So we discussed about the brainstem, and but as we just look the posterior view of the brainstem, right, of the midbrain, basically. So we have, like for example, if this is the posterior view, so we have two bulges, or you can see say a tubercles kind of things, which are arising from the posterior aspect of your midbrain, right? And we call them colliculus, right? So we have superior colliculus and we have inferior colliculus, right? Remember, this superior colliculus, which are two bulges on the posterior aspect of your midbrain, are responsible for vision. That's really important. We are going to discuss the entire visual pathway in detail. While the inferior two colliculus are basically, associated with the auditory reflexes, right? Auditory reflex. So we have visuospinal and auditospinal reflex, which we are going to discuss. So you should just keep in mind the superior colliculus, which are outgrowth, or you can say tubercles on the posterior aspect of midbrain, are basically responsible for vision, some component of vision, and the inferior are involved for the auditory, right? So we have a pathway that is known as spino collicular pathway, which we are going to discuss. So this is basically involved in visual vision, right? The next component of your brainstem is your pons, right? So let's discuss from where do the pons arises embryologically. So it arises from
Encephalon.
mesencephalon, right? Which we are going to discuss in embryology. Okay, what are the blood supply of pons? What's the blood supply of pons? If you guys remember, you were having a basilar artery, and there I just told you basilar artery gives some small pontine branches, right? Along with that, the anterior inferior cerebral artery, the ICA, is also going to supply the lateral aspect of your pons. So the medial aspect of the pons are going to be supplied by the basilar artery, branches from the basilar artery, the medial aspect, while the lateral aspects are going to be arising from the branches of, yes, hello,
The
ICA,
vegetables.
right? That's ICA, anterior inferior cerebral artery, okay?
Yes.
Okay. So what are the significant structures which will be present within the pons? The pons basically contains, okay, we discussed cranial nerve 3 and 4 are basically present within the midbrain. 5, 6, 7, and 8 are present within the pons. I'm going to tell you a rule of 4. You would know each and everything after this lecture, but just, just concentrate, right? So it means that the cranial nerve, the fifth cranial nerve, sixth, seventh, and eighth cranial nerve nuclei are present within the pons. But there is an exception. Keep one thing in mind. The cranial nerve 8 have a big nucleus. So half of it is present within the pons and half of it is present within the medulla.
Medulla.
Is it clear? Okay, so you can see that cranial nerve 5, 6, 7, 8, but 8 is big, half of 8 I can say, right? The reticular activating system is also present here within the pons. What is reticular activating system? Do you guys know? Reticular activating system. Yes. Reticular
Responsible
activating
for
system is basically a switch. It's basically a switch on and switch off of your brain. Just keep that in mind, right? Switch on and switch off of your brain. So these are basically a mixtures of your white and gray matter which are present within the pons. And you can just simply imagine that it's a switch, right? So for example, whenever in the morning we are waking up, so we have to turn on the switch in order to get currents into the brain, and the individual then just is awake, right? And the switch off, if I'm just sleeping, I have to turn off the reticular activating system, okay? So let me see, first of all, the students who are, okay. Okay, another thing which I want to mention, please just send, I have just send a link in the group. Just please fill that for the LMS. Where is Dr. Jamil? I can't see Dr. Jamil. Where is he? He's absent from several days, okay? Okay. Okay. So we were discussing about, okay, reticular activating system. It's basically a switch on and off system which is present within the pons. If we want, you can just imagine your brain as a, a tube light, and this switch on and off reticular activating system in the pons and connected down towards your, lower body. So if you are just turning on the switch, the current is going to flow and the brain is going to be awake. That is in the morning once you are just awaking. And if I want to sleep, I have to shut down, close the switch, and as a result of that, we are going to sleep, right? The brain won't receive any signals. The third structure present within is MLF, medial longitudinal fasciculus. What was your medial longitudinal fasciculus? Remember
No,
it?
tell her not to give bread. No.
Hello? Hello? Medial longitudinal fasciculus, right? So medial longitudinal fasciculus itself, as we discussed, it's a connection between different cranial nerve nuclei, right? As we discussed. So medial longitudinal fasciculus is going to be extending down, as you can see. Why? Because the sixth cranial nerve is present within the pons, right? And the third cranial nerve is present within the midbrain. So you can see that this medial longitudinal fasciculus is going to be extending down, it's going to extend up through the pons and the midbrain in order to have proper connection between third and sixth cranial nerves there, right? So medial longitudinal fasciculus is also going to be present within the pons as well, right? So it was all about pons. Let's just discuss our last component of the brainstem, which is medulla, right? Which is your medulla. So medulla is basically a derivative of your myelencephalon, right? Myelencephalon. Which arteries do the medulla get supply from? They're basically your, okay. So we have the medial aspect of your medulla and the lateral aspect. So the medial aspect of the medulla is going to be provided by anterior spinal artery or vertebral artery. So anterior spinal artery, if you just remember, the 2 or 3 of the spinal cord is going to be supplied by anterior spinal artery. It also gives branches to the medial aspect of your medulla and give it a blood supply, right? While the lateral aspect of your medulla are going to be supplied by pica, that is posterior, that is PICA, posterior. Yes, what was pica? Posterior
Posterior
cerebellar
inferior
artery, right?
cerebellar artery.
Yes, posterior inferior cerebellar artery is going to give supply to the lateral aspect of your medulla, right? What significant structures are present here? First of all, the cranial nerve 8. As I already told you, 8 is a big cranial nerve nucleus. So half of it is present within the pons and half of it is present within the medulla. What else? Okay, from the 8, then we have cranial nerve 9,
9, 10, 11, 12.
11, and 12. They are present within the medulla, right? We also have area postrema. What is area postrema? Really important, one of your U-word MCQ. At the back of your medulla, you have an area which is known as area postrema, which is your emetic center, right? What do you mean by emetic center? Here you have something called chemo trigger zone. So whenever certain things like certain metabolites can just stimulate your chemo trigger zone in area postrema, which can cause MSS, right? That is vomiting. Is it clear? And we also have inferior cerebral peduncle here as well. What is inferior cerebral peduncle? It's a connection of medulla with the cerebellum, as we discussed, right? In the spinocerebellar pathways. Do you guys remember that?
Yeah.
Yes, yes.
Okay, perfect. So it was all about brainstem. So in order to know each and every component of brainstem, we have a rule called as rule of 4. Rule of 4. It's really important to know rule of 4. And once you guys know this rule of 4, you can just answer each and every MCQ of your U-word, one of your real exam. If they're just telling you the lesion is on the right side, you have this kind of lesion, that kind of lesion. So knowing this rule of 4, you would just, localize a lesion, or localize the blood supply, which blood supply is just causing problems, So that's really important to know rule of 4. Right? So what does the rule of 4 state? Rule of 4 state that we have 4 rules. Rule 1, Rule 2, Rule 3, and Rule 4. The first rule itself have 4 points. The second rule have 4 points. The third rule have 4 points. And the fourth rule have 4 points. Keep that in mind, right? Okay, not exactly the second and the third. Okay. So the first rule would state that, okay, so for example, if this is your brain, your midbrain, pons, medulla, and your spinal cord. The first rule basically states that, okay, that above your midbrain, 4 cranial nerves basically exit your brain above the midbrain. 2 from the cerebrum, that is cranial nerve 1 and cranial nerve 2. What is your cranial nerve 1 and 2? The ophthalmic and ophthalmic. Cranial nerve 1 is for olfactory and
Yeah.
cranial
Yes.
nerve is optic, right? So olfactory
Yes.
and optic nerve basically comes from your cerebrum. We are going to discuss it in detail, right? And the other two, from the midbrain, as we discussed, that is cranial nerve, third and fourth. You can see above the pons, I can say we have 4 cranial nerves originating from the brain, 2 from the cerebrum and 2 from the where?
Midbrain.
From the midbrain. Midbrain, perfect. 4 of the cranial nerves arises from the pons. The other 4, 5, that is 5, 6, 7, but 8 is a big one exception, right? Half in the pons, half in the medulla. And the 4 cranial nerves arises from the medulla. That is, after 8 you have 9, 10, 11, 12. So it's the first point of rule of 4. Is it clear? But as we know that 8 is big, so half of the 8 is present within the pons and half in medulla. Is it clear? So this is the first rule of 4. Okay. Hello.
Yes.
Yes.
Perfect. The second rule states that whatever cranial nerve are divisible by the letter 10, they are going to be present medially. What do I mean by that? Let's start from cranial nerve 3 and 4. Can I divide 3 by 12? 3 into?
Yes. 4.
Right? Okay, can I divide 4 by 12? Yes, 4 into 3 is 12. Can I divide? Is 5 divisible by 12? No. 6
No.
divisible by 12? Yes, 6 into 2 is 12, right? 7 isn't divisible, 8 isn't divisible, 9 isn't divisible, 10, 12 is divisible, right? So it means that cranial nerve 3, 4, 6, yes, and 12 are present medially. What do I mean by that? The third and fourth are going to be present in the medial aspect of your midbrain. Why? Because they are divisible by 12. Is it clear?
Yes.
Hello?
Yes. Yes.
Okay. The six is basically present within the pons. 6 is again going to be present medially, while the other are going to be present laterally, right? And 12 again is going to be present medially within the medulla, while the other are going to be present laterally, right? So if we have any problem of, the lateral aspect of medulla is supplied by which artery? Yes, that was pica. It means whenever we have problem with pica, it can never cause problems of 12 because that is medially and the other are laterally, so it can cause problem with the lateral nuclei. So in this way, you are going to connect things. Is it clear? How to use the rule of 4? Is it clear?
Yes, yes, doc.
Okay. So what,
Yes, doc.
so what the third rule state? The third rule state that basically whatever comes from the word M are going to be present again medially within the brainstem. What comes from M? The motor pathway. Motor pathway. We discussed the descending pathway. Remember, corticospinal tract, motor pathway. It's going to be coming all over the brain, all through the brainstem medially, right? It's always present medially, right? Is it clear? So all of the motor pathway is present medially in the brainstem. Is it clear?
Yes.
Okay, perfect.
Yes.
What I'll start from M, the medial longitudinal fasciculus, as we discussed. Medial longitudinal fasciculus, it connects all of the, most of the cranial nerve nuclei with one another. So why do we call it medial? Because it's present medially again within the brainstem, right? It starts with M, it is present medially. Is it clear? What else start with M?
Yes, doc.
Medial longitudinal fasciculus. Do you guys remember? DCML, dorsal column medial lemniscal system.
Yes.
Medial
Yes.
lemniscus. Medial lemniscus. It was important. Okay, the dorsal column was carrying which sensation? Proprioception.
Reception, fine
Properly.
touch.
Vibration.
Yes. So as we discussed, first of all, you have fasciculus gracilis, fasciculus cuneatus. They are going to,
Modern systems.
yeah, the modern sensation, perfect. So they are going to be present within the brainstem immediately. They are going medially through the brainstem into your cerebrum. What else? The motor nuclei of the cranial nerve are also going to be present medially. The motor nuclei, like cranial nerve 3, it have a motor nucleus. What is the function of cranial nerve 3? It basically causes movement of your extraocular muscle, which we are going to discuss. Cranial nerve 4 is also motor in nature. The supra, which muscle do cranial nerve 4 supply? That is superior oblique, right? Superior
Yes.
oblique. Okay. The cranial nerve, okay, 5. 5 is? Yes, what?
Trigeminal.
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 Trigeminal also have a motor component. What's that? The third
Mandibular
one.
nerve.
Third, the
Wait,
mandibular
wait.
one. The mandibular one, which is going to supply the muscles of mastication, right? Okay, so it's the 5. The 6th cranial nerve, abducent, motor, lateral rectus, right? So it's also going to be present medially. The the 7 one, facial muscles, right? The 9 cranial nerve, it also have a motor nuclei, right? The 10th, the 11th, and 12th. So all of the motor nuclei of these cranial nerves are going to be present in the medial aspect, right? They start with the letter M. So we have 4 points here as well. Rule of 4. The third point state that we have, further 4 points, whatever start with M would be present medially within the brainstem. Is it clear? Hello?
Yes.
Okay. And the last rule of 4 basically said whatever start with the letter S are going to be present laterally within the brainstem. What start with S? The spinothalamic pathway. So what was your spinothalamic pathway? Do you guys remember?
Pain and temperature.
The primitive.
Perfect. Pain. So they are going to be present at the lateral aspect, in the lateral aspect of your brainstem. What else? Sensory nuclei of cranial nerve. S4 sensory nuclei of cranial nerve 5, trigeminal. They are also going to be present laterally in the brainstem. The sympathetic pathway. Sympathetic pathway comes from the hypothalamus down, right? We are going to discuss that in detail. It's also going to be coming through the brainstem laterally, right? And the spinocerebellar pathways we discussed, right? The anterior spinocerebellar and the posterior or dorsal spinocerebellar through the inferior and superior peduncle, if you guys remember, right? It's also going to be moving, in the lateral aspect of your brainstem. So this was all about brainstem. Let's just read it from our first.
Doc, I had a doubt. Sympathetic pathway is that one which comes down to the lateral horns, right?
Yes, we have lateral horns in the thoracic region. Okay, thoracolumbar, right? We have lateral horns in which, yes, the sympathetic from the hypothalamus is going to be coming there. The first order neurons from there, we are going to be having the second order neurons. So you're right, in the lateral horns, right? Lateral horns basically is having these sympathetic pathway, second order neurons. Okay.
Okay, Doc. Thank you.
You're welcome. So can you guys just tell me the page number of the topic which we discussed, brainstem? Hello? Hello?
Yeah, yeah, Doc, we are
This is
going.
your brainstem, right? Brainstem. So let's discuss brainstem from first aid. So you guys can see here that we have four cranial nerve above pons. That is one, two from cerebrum, three and four from the midbrain. The fourth exit the pons. That is five, six, seven, but eight is big. We know that half of it is present within the pons and half in the medulla. The fourth point, you know that the medulla itself is having four cranial nerve. The remaining others, the four cranial nerves are medial, which are divisible by 12, and we also discussed the ones starting with a letter M are going to be present medial, while starting with S are going to be lateral, right? Just write it down on your first slide, okay? So this is the dorsal, view of your brain stem. So we discussed the pineal gland. Remember, we discussed about the pineal gland. It's going to be present here at the dorsal view. Pineal gland basically secreted melatonin, and melatonin basically is responsible for circadian rhythms, right? So we discussed we have superior colliculus. That's important for the visual stimulus, as we discussed. Direct eye and head movement primarily to visual stimuli. What do you mean by that? Like you can simply imagine, for example, if you have a guy, he's standing and on his head suddenly a bird passes, right? Any bird is just flying upon near his head. So what would happen? This individual is suddenly going to move his head downward from the bird. Why? Because he would just see the bird and he's going to move his head down. Why? In order to like he would be thinking, what if the bird just hit my head? So he's going to move the head down, right? So it's basically called as which was spinal reflex, right? So you're seeing anything, and after seeing, you're having a movement, right? So for this, you can see the direct eye and head movement primarily to visual stimuli. To visual stimuli, whenever you are just doing any kind of movement, so this pathway is going to be responsible. That is, the superior colliculus, right? Similarly, we have inferior colliculi, that is auditory processing, direct eye movement to auditory stimuli, right? So, for example, if someone is singing, his voice is like too good, so you're directly going to look towards him. That's a movement to an auditory stimuli, which is in which your inferior colliculus is going to be involved, right? So eye movement to okay, eye above ear, superior colliculus. There's a mnemonic you guys can just see. Okay, okay. So it was all about uh, topics which are really important, and we did from first aid. So let's start from embryology. Let's start reading our first aid now, right?
Doc, Doc, could you explain this eyes over ears, superior colliculus, above inferior colliculus? That one I didn't get.
Okay, it's basically a mnemonic which they have just given in order to memorize what's the function of superior colliculus and what's the function of inferior colliculus. So eyes are above your ears, right? Okay, so the visual reflex is going to be for a superior colliculus, right? Superior is upward, and
Okay,
ears are
okay.
before inferior colliculus. Right?
Inferior. Yeah, yeah. Got it.
Okay. Okay. So let's discuss embryology, right? Okay. So you guys can see that we have three layers: ectoderm, mesoderm, and endoderm. The mesoderm is going to be having a structure called as notochord. Notochord is going to send some signals, and those signals are going to differentiate this ectoderm into neural plate. It's going to become thick, and once the plate become thick, it's going to start invaginating and start making a neural tube, right? And at the same time, the lateral portions of that neural plate are going to separate, giving you neural crest cells, which we discussed. Neural crest cells are going to migrate to different parts of your body, formation of different cells. At the heart, we discussed the endocardial portions are going to be made by your neural crest cells. We discussed the adrenal medulla is going to be derived of your neural crest cells, right? So, and notochord, the remnant of notochord we discussed recently in MSK is going to be your nucleus pulposus. Remember nucleus pulposus? Hello?
Yes.
Yes,
And the
yes,
Yeah,
Doc.
intracellular
and vertebral pad, we have fibrous annulus and nucleus pulposus, right? So you can see that the notochord, as we discussed, is going to be nucleus pulposus in the interventricular disc. It induces ectoderm to form a neuroectoderm, neural plate, as we discussed. Neural plate would, arise. It would just give rise to a neural tube and neural crest cells, as we already know. The lateral walls of the neural tube is divided into alar and basal plates. What are alar and basal plates? If you guys remember, I just told you if this is your, if it's your spinal cord, we discussed you have your posterior horn and anterior horn, right? The posterior horn are basically sensory in nature, while the anterior are motor in nature. Remember?
Yes, yes, doc.
Okay. So these sensory posterior horns are basically derivatives of your alar plate. Alar plate. And these motor horns are derivatives of your basal plates, right? So you can see the alar plates basically give rise to the sensory. Okay, it's basically going to be induced by a factor which is known as BMP, that is bone morphogenetic protein, which differentiate these lateral aspect of your neural plate into alar plate, right? And for the basal SHH, that is sonic hedgehog gene, which induces to differentiate these lateral aspect of your neural plate into the basal plate, and in the end it would just give you the motor anterior horns, right? Is it clear? Hello?
Yes,
Yes.
yes, doc. Yes.
Okay, so you can just read it from first aid. Okay, so the next one is regionalization of neural tube. It's really simple. First of all, we are going to be having prosencephalon, mesencephalon, and rhombencephalon. These three structures, right? The prosencephalon is further going to be differentiating into telencephalon, which give rise to these cerebral, the lateral aspect. And the other one is going to be we have telencephalon and diencephalon, right? Diencephalon is going to give rise to a lot of things which we are going to see. The mesencephalon is going to stay as mesencephalon, and in the end it will just give rise to your midbrain, while the rhombencephalon is going to be divided into two, that is metencephalon and myelencephalon, right? The telencephalon further is going to give rise to cerebral hemispheres and basal ganglia. Keep that in mind. You have to memorize it, right? We discussed basal ganglia in detail if you guys remember. The diencephalon is going to give rise to thalamus and hypothalamus and some of the parts of your retina as well, right? The mesencephalon is going to be same, the midbrain. The metencephalon is going to give rise to pons and cerebellum, while the myelin is going to give rise to medulla, as we discussed, right? So you can see the lateral ventricles, the third ventricles in the diencephalon. Okay, just give me a second. I'll do the lecture after Azan, okay? Hello? Hello? Can you guys hear me? Hello?
Yes, doc.
No? Okay. So you can see these are the structures which are derived from different, from the telencephalon, diencephalon. You guys can just see, memorize it, okay? And just try to make sense out of it. We already discussed each one in detail, right? So we have central and peripheral nervous system origin, right? We already discussed that in our general lectures once we were just having our general lectures. So we have neuroepithelium that's going to, in the neural tube, is going to give rise to CNS neurons, the ganglia, that these are the supporting cells, if you guys remember, the astrocyte, the oligodendrocytes, ependymal cells. If you remember, astrocytes are basically just like a star kind of cell, right? That's why they are called as astrocyte. They basically play a really important role in formation of your blood-brain barrier. We know that not everything can pass your blood-brain barrier. So there are some tight junctions of proteins called occludins, which we'll be discussing in blood-brain barrier topic, which is going to be next. It would be coming, right? So astrocytes are basically going to have information of your proper blood-brain barrier, right? Whatever just passes by any chance through this blood-brain barrier, so your astrocytes are going to pull it back, right? We have oligodendrocyte, which we discussed, are going to be myelinating the neurons within the central nervous system, the axons. Ependymal cells, if you guys remember, these are the cells which are lining your ventricles. Do you guys remember that? Ependymal cells?
Yes,
Yes.
doc.
Perfect. We discussed neural crest cells from where are they derived. We know that it would give rise to peripheral nervous neurons. If you guys remember the ganglion, I just already told you that, right? Autonomic ganglion, the sympathetic and parasympathetic, the TNS ganglia. So you have to memorize it, like Schwann cells, satellite cell, adrenal medulla, which is a big sympathetic kind of ganglion. The mesoderm are going to give rise to microglia, which are the macrophages of your central nervous system, right? So you can see, let's discuss our next topic, that is a neural tube defect, right? What do you mean by neural tube defect? It's really interesting and really simple at the same time, right? Remember, once we have formation of neural tube, right? We discussed we are going to be having neural plate. That plate is going to be invaginating inward forming tube. We have the superior aspect of this tube, or I would say the rostral end and the caudal end of this tube, right? So we have some pores kind of structures within both of these aspects. These pores must have to be closed. We should, these pores should be closed. What do you mean by pores? They're called as neuropores, right? These are simple, like defects, or you can say foramens kind of structures present within the rostral aspect of neural tube and within the caudal at the tail or at the head. Let me just make it really simple. You have these pores. These pores should be closed. If these pores do not close, we are going to be having a lot of problems then, right? And those problems are going to be listed here. That are the neural tube defects, right? Okay, so you can see failure of neural tube to close, right? So as we discussed that on the caudal and this neural tube is going to be having that defect, the pore, and at the rostral end as well, right? They have to be closed. If they do not get closed, what would happen? They normally get closed at the 4th week of development. And what leads to the closure of these tubes? Really, really important. Folic acid supplements, right? So before conception, basically a mother is, prescribed with folic acid supplements, because folic acid is basically going to help closure of your neural tube or neuropores. Is it clear? So those female, let's suppose if a female is taking methotrexate. Do you guys remember the methotrexate we discussed in immunology in detail?
Yes, doc.
Yes, trimethoprim sulfate and methotrexate. Who is going to be telling me about methotrexate? It's a anti-folate drug, right?
Yeah.
Anti-folate drug. So if someone is taking anti-folate drug, folic acid anti-folate, it means they're going to be having more chances of getting neural tube defect. Why? Because folate or folic acid is important for closure of neural tubes. Does that make sense?
Yes.
Like folate deficiency can also lead to neural tube defects. Okay, and certain teratogen valproate. Do you guys remember what was valproate drug? Used for it's used in bipolar as well,
Yes.
anti-seizure, we are going to discuss. Carbamazepine as well, which we are going to discuss in detail, can also lead to neural tube defects, right? Okay, what are how to diagnose the neural tube defects? Ultrasound, serum AFP. And how do we know that the serum AFP, increased maternal serum AFP in the amniotic fluid, and ACE in open neural tube defect? Remember, what is AFP? AFP is alpha fetoprotein, right? So if the pores are open, so you can just simply assume, okay, just give me a second, please. Hello. Okay, so we were discussing that if we have open neural tube defect, so the alpha fetoprotein, which is basically a protein of a fetus, it would just leak out into the amniotic fluid. So the amniotic fluid would be having a lot of AFP. Is it clear? So AFP is going to be elevated. Along with that, the AC, that is acetyl cholinesterase. Okay, what is ACHE? Yes, what is ACH? That's acetyl cholinesterase, right? Hello?
Yes, yes, yes,
You guys
doctor.
remember acetyl
Yes.
cholinesterase?
Yes,
That
we do.
enzyme degrades acetylcholine.
Yes, it was basically depleting the acetyl. So really important, you guys to have to keep that in mind that the ACHE acetylcholinesterase are basically present in higher quantity within the CSF, right? They are present in higher quantity within the CSF. So whenever we have open neural tube defect, so the AFP alpha fetoprotein along with the ACHE, they are also going to be more in amniotic fluid. Is it clear? And
Yeah.
open neural tube defects, right? Okay. So whenever the posterior neuropores fails to close, we are going to be having a condition called as, that is spina bifida. And whenever we have failure of closure of anterior neuropore, it's going to lead to anencephaly. So let's discuss spina bifida and anencephaly in detail. These are really simple, configuration. There in the first slide, they have just drawn it really interesting way in really so spina bifida occulta. It's basically a closed neural tube defect. It isn't an open neural tube defect. In spina bifida occulta, you can see that there is problem with the vertebral body, no problem with the with your spinal cord, no problem with the with the layers, the meninges, no problem with the CSF which is surrounding, right? So basically in spina bifida occulta, it's a closed neural tube defect, and this the neural tube is going to be closed. It's going to be closed, but the problem is with the vertebral body. So what would happen? The vertebral body won't form at this place. So if the vertebral body isn't forming, so you can see that these different meningeal layers and spinal cord are going to be present. So there are increased chances of getting these structure damage because we do not have that bony support, right? So on that you'll be having here a tuft of here. Let's say the specific for spina bifida occulta, right? So it's a closed neural tube defect, failure of caudal neural tube to close, okay, but no herniation. That is the spinal cord along with its meningeal layer are going to be present within its specific within the proper place. They won't herniate through this defect. That's really important, right? Dura is intact. We know that. We can see it. Usually seen in the lower vertebra, as we discussed, it's going to be associated with tuft of hair on the skin or dimple here within the skin, right? The other one is meningeocele. What does the name meningeocele indicates? Meninges, problems with meningeocele, right? And meningeomyelocele, the word myelo basically stands for the spinal cord. So meningeocele won't be having herniation of spinal cord there. So you can see here in meningeocele, only the meninges are going to be herniating outward just like that, okay? Okay, while in case of myelomeningocele or meningomyelocele, the meninges along with the spinal cord are going to be herniating outward through that defect. Keep that in mind, right? So again, there an example of open neural tube defect. The meninges are going to be herniating through the bony defect, while in meningomyelocele, both the meninges and the neural tissue are going to be herniating through the defect, right? What happens in myeloschisis? What do you mean by schisis? We discussed it in MSK. Yes.
Protrusion coming out from a cavity.
Yes, perfect. So you can see it's an open neural tube again, and it's we are going to be having unfused neural tissue without skin and without meningeal covering. So we are going to be having pure, spinal cord just coming out of the defect, right? Keep that in mind. Anencephaly is whenever the anterior or the rostral portion of the neural tube do not closes. So we are going to be having anencephaly, right? So it's an open neural tube defect. And as it do not closes properly, we won't be having formation of the forebrain. No forebrain. Formation, okay, no forebrain, no formation of the skull. The skull bones. Really important to know. And along with that, no formation of mouth. Baby's mouth would not form properly. So if the baby mouth isn't forming properly, so can the baby swallow the amniotic fluid?
No.
No, the baby cannot swallow the fluid, which is going to lead to polyhydramnios, right? Polyhydramnios, which means a lot of amniotic fluid within the cavity, right? Is it clear? Hello?
Yes.
Yes, Doc.
Okay,
Yes.
okay, perfect, right? So the next topic is brain malformation. The first one is hollow prosencephaly and the other one is lesioncephaly, right? What happens in hollow prosencephaly? It's a failure of forebrain to divide. So normally we know that the forebrain divide into two, hemispheres, the right and the left, right? But if we have failure of the prosencephalon forebrain, as we discussed in our embryology, to divide, so we will be having a defect that is, divide into two cerebral hemispheres. The developmental defect is going to arise at third and fourth week, seen associated with SSH mutation, that is sonic hedgehog, okay, associated with Patau syndrome and fetal alcohol syndrome, which we are going to discuss in detail in our trisomies, the Patau syndrome and the fetal alcohol syndrome in the teratogen chapter, right? In our reproductive module in detail, right? But here you should only just remember that hollow prosencephaly can be seen in Patau syndrome and fetal alcohol syndrome, right? What would be the presentation? Present with midline defect, that is monoventricular. A single ventricle is going to be present. Why? Because we do not have proper division into two cerebral hemispheres. We know that. Along with that, the fused basal ganglia. Basal ganglia on both sides of your brain are going to be fused. Is it clear? Hello?
Yes.
Okay.
Yes. Yes.
And we are having cleft lip and cleft palate associated with the hollow prosencephalon. You should just keep that in mind. And we are going to be having something called hypotelorism. What is hypotelorism? Do you guys know that? Yes.
No, Doc.
Okay. So in the hypotelorism, basically the space between both of your eyes are going to be very, a lot of space between both of your eyes. That's called as, you know, hypo, like where you have a lot of distance between the two eye. That's called as hypotelorism. Is it clear? What
Yes.
is cyclopia? Yes, in cyclopia,
One
an
eye.
individual is going to be a single eye,
One.
right? Okay, a single eye. Okay, we are going to be having proboscis. What is proboscis? You guys know? A big nose. You can just see the pictures and they're really interesting. You would know it, right? Increased risk of pituitary dysfunction can lead to diabetes insipidus. It's obvious that your entire brain anatomy is disrupted. So we can get diabetes insipidus. What is diabetes insipidus? We discussed in detail. That is no ADH. No, it can be central, it can be nephrogenic, right? What is lesioncephaly? In lesioncephaly, the brain is going to be really smooth. Normally, we know that the brain have a lot of gyri and sulci, right? Those structures just like that, the gyri and sulci, right? In lesioncephaly, it's failure of neuronal migration. We are going to be having smooth brain, which lacks the sulci and gyri, right? And it is going to be associated with dysphagia, seizure, microcephaly, and facial anomalies. You have to memorize it, right? So if the brain is really, smooth, we do not have proper, you know, in order to get memory, once an individual is just memorizing a lot of things, so these sulci and gyri are really important for that, right? So whenever the structures of your brain is disrupted, it can lead to seizure, a lot of, electrical problems, and dysphagia as well, because certain eating centers can also be disrupted. microcephaly. We do not have that proper, you know, a lot of gyri, so the head is size is going to be really small. In this way, you can just remember, and some facial anomalies, right? Is it clear?
But doc, if there is no sulci and gyre, how will his brain function? Like the other functions in the cortex are based on sulci and gyre, right?
The function won't be proper. We won't be having a proper function, right? But the presenting feature, the most, possible or probable, presenting features are going to be like that. So the brain is going to be, it's not going to be normal functioning of the brain. But till this point, lesion cephaly, you should only just remember that the brain won't be having sulci and gyri. In order to differentiate it from, on like basically on this imaging, you should know, right? So here you can see we do not have sulci and gyri. In the U world, you can get this MCQ in which this same picture is going to be given and they're going to be asking you diagnosed, right? They won't get into a lot of details, right? So here you can see this is the normal brain, right? Okay, the basal ganglia. Okay, it's not a normal brain, by the way. It's in Holland prosencephaly, and this is the lesion cephaly. Is it clear? Hello?
Yes, yes, doc.
Okay, so it was all about today's session, and we are going to continue it tomorrow, and we are going to discuss the remaining things from first aid. Just get ready for that. We are going to be having some interesting, and first of all, we are going to do pathology from pathoma again, and then we are going to refer to first aid. Keep that in mind. So this neuro is going to take a little bit time, so just bear me for a while. Okay, thank you so much. Thank you, and have a great evening.
Thank you, Doc.
Doc, the PDF, please don't forget the PDF, doc.
Yes, I'll just send it right away. Okay.